Hi, I'm Dr. Lauren Olson. I'm a psychiatrist in Des Moines, Iowa, and I've been practicing psychiatry in Central Iowa for about 25 years. I've decided to make this video about the use of Skype in psychiatry because I think it can improve access for a number of underserved patients. I've been practicing for about 25 years, and I practice in multiple sites throughout the state. During that time, I have spent a lot of time behind the windshield going from one practice to another. Throughout the time that I've been practicing, one of my major concerns has been access to treatment. Although we have more psychiatrists per capita in the United States than in any other country, about 50% of the people with serious and persistent mental illness are not currently being treated, and only about 7% of the people who have serious mental illness are able to access services which are considered to be evidence-based practices, those practices which are generally considered to be the best practices available in psychiatry. The problem, I think, is in the way that psychiatrists are distributed and the way that we use our time. I don't think necessarily there's a shortage of psychiatrists, but really a shortage of access. Several years ago, I used the Iowa cable network as a way of seeing patients. I found it to be quite useful clinically. Most of the time, the patients that I was interviewing would forget that he or she was on camera, and the quality of the interview that I was able to do, I felt, was very, very satisfactory. In fact, one patient who was 60 miles away once asked me for a glass of water, and another schizophrenic patient said that he actually preferred seeing me over the internet. There were some problems, however, with it, and it was pretty labor-intensive and a fairly inefficient use of my time, and I really didn't feel that it was very satisfactory and discontinued it after a while. A few months ago, I was contacted by my daughter, and she suggested that I try Skype so that I could be able to be more present with her family in Ohio and also with my daughter in Seattle. I tried Skype and I liked it. I found it very easy to use. It's not much more difficult to use than using a phone. And I began to remember the experience I'd had in psychiatry with the cable network. So I tried it with a few patients, and the patients generally found it satisfactory. There are, I think, three particular advantages of Skype over what I've used previously. One is it's quite inexpensive. A camera can be purchased for less than $100 in most places, and many laptop computers have them built right in. Consequently, it's quite portable, and I could practice, in theory, at all 6 locations that I currently practice, all on the same day, by taking myself there via the internet. It's, I think, an efficient way to use our time. There are some negatives. It does lose some of the intimacy that's present usually during a psychiatric visit. However, it's not a question about whether or not it's perfect, but whether or not it might be better than what's available now to other people. It is secure. I have checked with the vice president of Skype and an independent evaluator, as well as a local hospital, and all three have assured me that the security is adequate for the purposes that we would need it for. I think that there are a couple of best uses of it. One would be for routine follow-up of a patient that is well established. There isn't quite the need for developing a therapeutic alliance at that point because it's already been established. And so the intimacy that's required in the evaluation is already present in that situation. The other two uses which I think are important and will become increasingly significant are to use it for consulting with a psychiatric or mental health clinic situation. I currently use it with a situation where there's a nurse practitioner, licensed social workers, chemical abuse counselors, and it's useful in terms of doing consultations with patients and recommending treatment, which will then be provided for the members of that clinic and not directly by me, except on an occasional basis. The other use that I think that it will have, potentially at least, is with being a member of a primary care clinic. I could, in fact, be a psychiatric consultant for several primary care clinics at the same time and never leave my office here. I think that would be a useful way to use the skills that we have as psychiatrists. Of course, there are issues about billing. So far, there aren't many insurances that will pay for it, although the Title 19 administrator here in Iowa is setting up telemedicine clinics and will reimburse for those services. For some patients which come from quite a distance, they may be willing to pay out of pocket because the time that they use in commuting to my office is often it's often necessary for them to take a full day off work, as well as the cost of their transportation. So even paying out of pocket may be a better investment for them than to depend on insurance payments. I think that this will continue to grow as time progresses, and I would expect to see a lot more of it in the future. Thank you for your time.